We need to have a standardized of pharmaceutical reps.
The people that provide education, the doctors.
Who is the chairman and CEO.
The fascination the public has. The impact on society, the impact on unemployment.
One of the principles in our bill is that the person who's doing that peer review has to be of the same or similar specialty and treats the conditions for which they're reviewing.
Welcome, everyone, to the Unscripted Podcast, where we discuss all things healthcare and pharma related. Today, I'm very excited. We have a special guest, Representative Timothy Reeder, who is a representative of the 9th House District of the North Carolina House of Representatives. He's also the past president of the North Carolina Medical Society and lead sponsor of the Care First Act, House Bill 434, which we're going to get into. Representative Reeder is also a physician by background. He earned both his undergraduate and medical degrees from Ohio State. Representative Reeder, welcome to the podcast.
Thanks very much for having me. Really excited to talk to you today.
Absolutely. I looked at your background and I was really fascinated in the fact that you're so focused on patient care and reform, especially given the fact that you have a physician background. You're a physician by training, and so obviously you have a unique perspective on this versus a lot of folks that work in the government and serve. So maybe let's talk about that first. Let's talk about the Care First Act that you spearheaded. You have a question?
Yeah, no, and thanks very much. And so I still have a perspective. I'm still practicing full time. So in North Carolina, it's a part-time legislature that only pays about $13,000 a year. So I'm still full-time faculty at East Carolina University. In fact, this weekend I'll be doing shifts in the emergency department. So
oh wow,
I'm
okay.
a full-time physician and a part-time theoretically legislator. And I was really happy about the Care First Act that we sponsored this year. In Care First, it's an acronym, and it stands for cut authorization red tape efficiently, facilitate interventions rapidly, start treatment. And so it's really encapsulated that name is what we're trying to do is improve and reform the prior authorization process. I know that the program started off well-intentioned many years ago, and it was looking at complex, high-cost interventions. But what's happened over the years is it's morphed into something that I think is really unrecognizable and in some respects not defensible. We know that there's too many things that fall under prior authorization that aren't expensive, that are routine, that really just burden the patient primarily, the physician, and there's a little bit burden on the insurance company. And from my perspective, I'm not sure the value in the cost effectiveness of that. And so I'm in my second term in the General Assembly in North Carolina, and we submitted a bill last year and we got it in late and it just didn't get a whole lot of traction. So we've been working over the last 2 years to make the bill better, to enculturate the idea and the issues so that there's more recognition amongst the legislators about why this is such an important issue.
So you bring up a really good point. Initially, when prior authorization was implemented, it was meant really to make sure that there were important guardrails in place so that patients got the appropriate treatment. Why do you think it's evolved the way it has, where it's become so difficult now from an administrative perspective to get patients the treatments that they need, and it's become such an administrative burden?
That's a great question. And I don't know why and how it evolved into this, other than I think in talking to representatives of the insurance industry, they feel like it's a really important tool to save money and cut costs. And I think there's something in there that's probably true, but not completely. And so one of the stories I keep telling is I have a friend who's on a hormone replacement. He's never going to make the hormone before. He's going to be on it the next 40 years of his life. But every year, this medication comes up for prior authorization. So he knows every January he's going to spend a couple weeks trying to get this prescription refilled. And that makes no sense to me. And it can't be financially beneficial for the insurance company, for the physician who has to do the paperwork, and most importantly for the patient. And that's a simple example. When we talk about gene therapy for sickle cell, that probably does deserve prior authorization. If we're going to do a kidney transplant, those are the things that absolutely need some oversight and need that. But there's too many things now routine imaging, refills on medications that just don't make any sense. And so I think that there's growing recognition amongst everybody that the system that we have in place is not working for the patients for sure, for the physicians, and I would venture to say for the insurance companies, but I think it's baked into their DNA that they have to have this program. And so that's why we've got this legislation to try to improve that system.
You obviously have heard of the story with the United Healthcare CEO being, savagely murdered, Luigi Mangione, and
Yeah.
that whole situation. And obviously, nothing justifies what happened. It's a brutal murder and it's a terrible
Yeah.
situation. Do you think, though, a story like that really brings to light to the American public just how burdensome prior authorizations can be? Kind of what do you make of that? Because obviously, in that story, this is an example of someone that was pretty frustrated with the healthcare insurance system. What are your thoughts on that?
Yeah, it is a terrible situation, and there's nothing that justifies that violence for sure. I think that the frustrations of patients with prior authorization has been growing and growing as more and more people were faced and had to deal with this, both from the patient standpoint and the physicians. And so, unfortunately, that tragedy brought to light what I think many patients were suffering with, but they didn't recognize how big and widespread that issue was. And so I think that's why in North Carolina, there's growing recognition on both sides of the aisle in both chambers that we need to do something differently. And I had conversations with the health plans and insurance companies, and they have said, well, we want to keep talking. Let's figure this out together. And my frustration is that we had a bill last year, so we've had a couple years to talk about this, and we haven't seen any action. And I think for me, we're just past time to allow more discussions to go on because some of this behavior is really egregious. One of the things in our bill and many bills that have passed around the country is the whole concept of peer-to-peer review. And so one of the other physician members, there's only two in our General Assembly, is a physician. He's an OBGYN. And he had to do a peer-to-peer for a complex adnexal mass, right? A big tumor in the pelvis that, from his perspective, needed surgery because there was a real risk of cancer. And the peer, I'll put air quotes, that he was talking to was a psychiatrist who didn't do this work. And their response was, well, can't you try birth control pills first? Which would be appropriate for an ovarian cyst, but not at all for this. And so one of the principles in our bill is that the person who's doing that peer review has to be of the same or similar specialty and treats the conditions for which they're reviewing, because it makes no sense to have somebody unqualified to weigh in on that.
Absolutely. I hear that a lot. I mean, which is insane, the fact that you would have people that are reviewing this and providing their opinion or making decisions, and they actually don't understand the underlying kind of clinical context and situation. Now, I'm curious, for you, what was the turning point that kind of compelled you to want to publicly advocate for reform around prior authorization?
When I came into the General Assembly in 2023, it was an issue that I knew of and was aware of. But as a freshman, you only have limited authority, limited influence, and you're really just trying to learn the system. So we put a bill in, and it took a while for me to get my feet under myself to understand just the process. And so one of the things that we did coming back into the session, which started in January, I was much more prepared. We had a better bill. We had talked to more people. And when I say we, me as a physician, as a legislator, other medical community, the entirety of the medical community and advocacy groups. So we were better prepared to walk in with, here's a bill, let's get this moving through the process. We were
Mm.
able to generate publicity because we were just more prepared for it. So the idea and my interest in this has always been there, but I'm just better able to execute this year.
And do you think that this issue, I mean, I would imagine it would be, but do you think this is really a bipartisan issue? I mean, is there support from both sides to kind of push this reform on prior authorization?
Absolutely. Even last year, when we weren't as prepared in the House, we passed a prior authorization bill 112 to 0. So there was no opposition in the House. Because we got started late, we didn't have enough time to get it through the Senate and enacted into law, just because as a part-time legislature, we really just ran out of time. And so the support on both sides of the aisle is tremendous.
Yeah, I mean, it would seem to me that this is really an issue that both sides would support it, and I wouldn't imagine there would be any contention from the other side. One of the things that I'm curious about is how do you balance, I guess, the need to reduce healthcare costs, which is, the goal of prior authorization, with also the ethical obligation to put the patient care first, and at the same time making sure that these payers, from their perspective, still are profitable. Like how do you manage that? Because right, this is they're not doing charity work, right, per se. So I guess how do you deal with that, and what are some of the challenges you've seen in kind of addressing that?
I think there's a number of ways with which to do it. And I think the first one, and in the insurance companies, the plans, they've acknowledged that some of the things that they do are not cost effective. I was talking to one of the plans, and they, and we've been talking about this for a while, and I've been saying, what are the procedures that you're reviewing that don't pan out? And so one of the plans said, we looked at our tonsil and adenoidectomies, and they said over the course of the year, we saved $17,000 on those prior authorizations. And they said, that's dumb for us to do that because we're not saving any money and we're incurring cost and we're putting cost on the physicians and the patients. And so that was an example where they just said, we're going to stop doing it, really through just conversation. And so going back to, I think that there's a legitimate role for this for things that are big, expensive, they're complicated. And that's especially the cost of pharmaceuticals. That is a big driver of the cost. And especially when we get into biologic agents in the gene therapy, that's, I think, still very valuable to do that. But again, the reviewers have to be knowledgeable. To say we're going to have a pediatrician or a psychiatrist reviewing indications for gene therapy for sickle cell, that just doesn't make sense. We've got to match that up. And and I think that when we talk about the cost of care, the plans, the insurance companies, they're easily able to say, we're saving this much money. This is what it cost us to run the program, and we've saved this money. The difficulty I have with that is that nobody is accounting for the cost to the patient. What is their intellectual, emotional, financial cost to not get better faster? And that's not calculated in that cost curve. The other thing that's not accounted for is the cost on physician practices. There was a study out there that said on average, it costs the insurance companies about $3 per case. It costs the physician practice about $11 per case. And so $14 per case, and obviously there's variation, that adds up very quickly. In North Carolina, we estimate that there were 60 million or cases that went under prior authorization. So 60 million times $14, that's a tremendous cost. But the only thing that we're calculating right now is what was the cost and what was the savings for that insurance company. And when I'm talking to physician practices, I joke, what I'm hoping this bill will do is allow you to fire some employees that are doing prior authorization or move them to other things like value-based or patient care or something that really is meaningful.
Well, this is why, like we were talking about before the segment, I think it's really important that those individuals within the healthcare provider office or the health system are trained and have education around prior authorization, because what we hear all the time in our organization is how many of these folks actually don't have the training, the education, the background to be able to process these quickly. And what we've been able to do is through education help to mitigate some of those effects. So I do think that, education in these situations helps a lot because ultimately it helps to save them time and money. Let's shift gears a little bit, kind of related to healthcare costs and talk a little bit about what's happening now in the country at a national level. Obviously, you've heard about the tariffs within the pharmaceutical industry that the Trump administration wants to impose. And I'm curious to kind of get your take on how you anticipate those tariffs might impact healthcare costs. Because, myself being an ex-pharma guy, and I'm sure you've seen the news this week, a lot of the big pharma companies, Roche, Lilly, Novartis, they're looking to invest, they said, at least 50 billion in manufacturing here in the US. But a lot of people are afraid of higher costs. Some people are afraid because of some of the tariffs on China, for example, that we're not going to have access to certain, generics, for example. There might be supply issues in the medical system. I'm just curious to hear what your take is on the tariffs overall. Do you see any positives from the tariffs long term? Just, what's kind of your opinion on it?
I think it's a great question about the effects of tariffs on healthcare costs because I think everybody, you hear about the automotive and the airline industry and big manufacturing, but I don't think there's been that much discussion in the press about the cost on healthcare and particularly pharmaceuticals. And we know, that many of the precursor chemicals are not made in the country. So even if we said we're going to shift manufacturing here and make the pills or the sterile injectable, we've still got to get those precursor chemicals from somewhere else because they're just not made here. And so I think it's a real concern. The tariffs in general, but particularly in healthcare. And people ask, and we talk about this, and what I say is a state representative, I'm like the rest of the country. I can't influence that so much. So I just need to sort of hold on, plan the best I can for what may happen. I do think the idea of insourcing and producing more medications in the United States is good for a lot of reasons. It's good because they're good paying jobs, that it is, I think from a national security standpoint, I think it's important and helpful. And in particularly in North Carolina, I don't know if I'm sure you do, North Carolina does a lot of pharmaceutical manufacturing. We have a plant in North Carolina, in my county, Thermo Fisher, that employs 2,900 people, and they make all sorts of sterile injectable. There's another company that makes pills, and they're contract manufacturer. So in North Carolina, bringing in those industries is really important as an economic driver for us as a state. The other thing that we make, and we learned this after Hurricane Helene, that Baxter has a huge plant where we make tons of IV fluids. And so that is also another place where North Carolina does a lot of manufacturing.
Yeah, I mean, I think when it comes to the tariffs, my perspective is that it won't really impact cost for a lot of your specialty or brand products necessarily,
Yeah.
because the profit margin there for the pharma companies is pretty high. They'll absorb some of that cost. I don't think they'll pass it on to the consumers. For the generics, really the cost of generics today for most patients are pennies on the dollar. There may be some increase in cost to your point because they make a lot of the raw active ingredients in China, but I don't know if the average patient at the pharmacy counter will feel a lot of those effects. I do think I agree with you. I think long term there's some positives because it's better. I think it's more from a stability standpoint, really, for the country to have these products manufactured in the U.S. and not be so reliant on places like China and Mexico and et cetera. So, I could see some of the short-term issues potentially, but I think long-term for the country, it's a positive overall.
Agreed.
Let's talk a little bit about, what's happening now within the White House when it comes to the Make America Healthy Again initiative under RFK Jr. I'm sure obviously you've heard about, that
Yeah.
initiative and what's going on there. I'm curious as a physician, what's your take on that in terms of, his perspective on really trying to hold pharmaceutical companies more accountable, and food companies more accountable. You're obviously a physician, as you mentioned at the outset. You're still practicing. You're seeing patients. You've been practicing for some time. What have you seen over the years in terms of some of those external environmental factors, food, diet, etc., overall on patients' health and the preponderance, for example, for things like diabetes, cancer, etc.?
I think it's a great question. And I know as a physician and you that much of what contributes to health is not healthcare, right? We can do a lot of incredible things treating cancer and heart disease, but foundationally and fundamentally, many of those are dietary, exercise, lifestyle things that contribute to that overall health. And so I think if you look at what the US spends on healthcare and the social determinants, it's similar to other countries, but other countries spend a lot more on the social determinants and less on healthcare. And so I think if we, as a country, as a culture, can start to think about the things that we do that make us unhealthy, and then the reverse things that we can do to make us more healthy, that has a whole lot more return on the investment. Okay. We still need to invest, and the US still leads in the development of healthcare, and that will never go away. But if we can get people talking about exercise and diet and the things that we eat and the things that we do or don't do for our health and for exercise, I think that's a great conversation. I think that some of the concerns that I hear is, certainly we've heard about vaccines, we've heard about fluoride in the water. So there's some things that I do worry about, because sometimes when politicians, leaders talk about things in the theoretical or abstract, or we need to have more data, sometimes that translates into people thinking that's now fact and they can make important decisions based on that. And
Yeah.
I think the health system, the public health system, the medical community, I think that we need to be cautious and also humble enough to say these are things that we know that are good, and these are the things that are bad that we know. And there's a lot of things in the middle that we're just not quite sure about. And being cautious and overreacting either way to those. And so that's what I think about, not just him as an individual, but the public health system, the preventative healthcare system, the sort of global health system that we think about.
Yeah, I mean, I think in premise, the initiative is good. I think it's going to be a lot about the execution, to your
Yeah.
point. So I think how that gets executed, and from a concrete perspective, what actually are the outcomes that we're looking for. Again, theoretically, it sounds very good. Now, I'm interested about your background. Like I mentioned, not a lot of folks that are state representatives are physicians by background. And I guess what prompted you to say this is something you want to do to serve in your district? What kind of was that trigger point that made you decide that you want to do that? You're a physician, you have a comfortable lifestyle. What made you want it to serve?
Yeah. So I could tell you a really long story, but I'll try to make it brief because we only have limited time. I had been very involved in health policy in the organized medicine, and I was involved in the North Carolina Medical Society for a long time. I was on the board. I was the president of the Medical Society in 2019, and we represent about 7,000 physicians and PAs across the state. So I had done a lot of work in advocacy and healthcare policy, but I had thought maybe briefly at one point, would I ever run for office? And I said, there is no way in heck. It's not my personality. It's not what I envisioned doing. And I got a phone call, and it was October the 25th of 2021. And someone said, we think that you should run for this seat. And he kept saying we. And I said, who are these we that are out there? And unbeknownst to me, a seat was going to be open. I'm unfortunately or fortunately, depending on the viewpoint, in one of those purple seats. And we've had a physician in this seat before. And so they said, this is a seat that's winnable, that we need a physician voice. Would you consider it? And they gave me a whole week to decide if I was going to jump into that, literally. And there was two
Wow.
things that compelled me to do this. One is that in my practice in emergency medicine, I see and saw the problems in our society on a daily basis. I saw the effects of a broken families, of violence, of substance abuse, of mental illness, of the elderly, all of those things I saw on a daily basis. And I thought that my voice would be helpful in that conversation. The other thing that primarily that drove me is I feel like the profession of medicine was under attack from a lot of different forces. And if I, as a physician, couldn't step up and advocate for the profession and our patients, then that's a lost opportunity. So those were the two things to help compel me. And related to protecting the profession, I had done a lot of work and talk helping physicians be better advocates because we, in general, don't do a very good job. And I thought that I could use this role to help encourage, cajole, threaten, embarrass physicians and our patients in becoming more active in healthcare advocacy.
That's great. Why do you think, or in what way do you think physicians are under attack in terms of the profession as a whole?
Yeah, the financial pressures, the pressures that we're trying to address in the first in the Care First Act, insurance companies, big health systems, private equities are all trying to interfere in what I think is the foundation of our profession is that patient-physician relationship. And that's what I still teach at the med school. I try to reinforce that all the time, that we can talk about studies and population and health, but what makes our profession so important to me is that interaction with the patient. And there's a lot of forces that try to get in the way of that. And so that is just sort of baked into my DNA. And in using this role to protect um, that relationship. And that's really what drives me and gives me a lot of energy to do this.
Now, like I mentioned, I come from the pharmaceutical industry, and
Yeah.
there's this, we call it a stereotype or this perception that the pharmaceutical industry has a big influence on physicians, on their prescribing. Uh, have you seen that? And I guess what's your take on that? Do you think that that's true, that pharma industry can negatively influence physicians, or do you think that there could be some force for good there?
I think there's the pharmaceutical industry has developed incredible treatments for all sorts of diseases, incredibly rare diseases, incredibly common diseases. We would not have the health and healthcare and life expectancy that we do have without the pharmaceutical industry.
Right.
Okay. Now, I also know if we go back when I started, we had a pharmaceutical rep feed us lunch all the time and give us pens and things like that. And from my standpoint, the data was fairly compelling that we could be influenced, sometimes not always in the best ways. And so I think getting out of that relationship, and there was, I think, from my perspective, a lot of abuses before I started practicing, and that was incorrect. And I think there's a nice balance now when reps are talking to us. It is much more scientific. It is less sales, and it is more how do we help out so that you understand why this particular intervention or treatment is what it should be. Um, and so I think that we've gotten better at protecting, especially our learners from that undue influence.
Mhm. Well, this is, why we at the ACMA, one of the things that we really advocate for are standards for professionals in the pharmaceutical industry, like
Yeah.
pharmaceutical sales reps and medical science liaisons that go out and educate physicians and other healthcare providers. We're big believers that there should be some type of benchmark or standard. And, I've actually had meetings with the former FDA commissioner, Dr. Janet Woodcock, about this, who's a big supporter of the work that we do. And I think that in a lot of physicians I talk to, they're also in agreement the fact that you need to have standards. It's important. It's actually before we came into existence, almost now 10 years ago, there was actually no standards, believe it or not, for pharmaceutical reps, for medical science liaisons in terms of meeting certain, competency standards in terms of knowledge and whatnot around not just compliance, but in terms of how to provide information to healthcare providers. So I agree with you. I think we've come a long way, especially in the last 10 to 15 years, in the positive direction. And I think that that needs to continue. From your take, do you believe that having standards and a benchmark is important, kind of a standardized benchmark for those pharma professionals that engage with healthcare providers?
So I think that there has to be a level of professionalism in this because it is a professional interaction, and we have medical ethics. And so having standards to say we're going to conduct ourselves from the pharmaceutical industry in a professional, ethical way that seeks to inform without undue influence, I think is really important. Um, and I think that that makes sense for everybody because, as you know, the medical literature is exploding, and it's impossible for anybody to keep up with
Yeah.
all the latest advances. And so I think that there's a legitimate role for industry to help work with physicians and systems to say, this is some evolving education. Let's work on this.
Yep.
One of my great experiences that I had in a research project several years ago is working with a company, and we were trying to screen for HIV in asymptomatic patients in our emergency department. And they had a program to help us set up for sort of opt-out screening. And so we would say, and we still do today, we can look at our EMR. You haven't had a test in a year. You're in this age group. We're going to test you for HIV unless you decline. And we picked up hundreds of patients who were infected that didn't know.
Wow.
And that was a program that was supported by a pharma company. And a cynical person would say, well, because they make HIV drugs and they're just trying to find patients. Well, yes, that's true. But I know that patients who would have otherwise not been found to be infected got identified and they got treatment. And it wasn't always their drug because there's a lot of manufacturers. But I know that there's patients and families and people down the road who now are better off because we were able to do this program.
Absolutely. I don't know which company that was. I worked for Gilead Sciences years ago, and the truth is, Gilead, helped to really stop death related to HIV. Gilead, AbbVie Pharmaceuticals, before that, it was basically a death sentence, right? If you ended up getting full blown AIDS. Same thing with hepatitis C. I remember back in the day where Gilead's, our CEO went before Congress. They were asking him, why are you charging $84,000 a year for this hepatitis C drug? But as the part of the issue is, yes, it's a high short-term cost, but a lot of those patients go on to eventually get hepatocellular carcinoma, might have to get liver transplants. So the overall cost in terms of healthcare burden ends up being greater. So I agree with you. I mean, pharma does a lot of important work. It's good. Yes, they make a profit. I mean, they're for-profit companies, but there's a lot of important work that they do. I just think, like as you just mentioned, it's important to do it and make sure that you're complying with certain professional standards, and that's assessed somehow,
Yeah.
by an external organization, and make sure that they're held accountable. I think that's incredibly important. Last question I have for you, um, thinking about, the work that you do as a physician, can you share maybe one story going back to prior authorization where it really kind of just, as a physician, maybe, a story that was compelling that, really shows the impact that prior authorization can have, in terms of patient outcomes and treatment?
Sure. And you'd think as an emergency physician, prior authorization doesn't affect us that much because you're in an emergency department and so we're not having to get prior authorization. But what's interesting is when you start talking about this, there is not a single person that I've met in the medical or in the legislature or where else that doesn't have for themselves or someone in their family a story about prior authorization. So it's just become ubiquitous. But one of the stories from the last month in our emergency department that helps encapsulate this is we had a patient who had back pain that had been going on for weeks, and they had been trying to get an MRI through their primary care physician, and it had been delayed and denied so much that when they finally got in to see us, they were having neurologic findings, and they were having significant pain. So they have been denied this MRI for weeks. They come into us. Now it's an MRI emergency in the emergency department with the hospital costs. We find a significant lesion that they then go directly to the operating room.
Wow.
So instead of something that could have been diagnosed and planned to say, we're going to schedule this surgery, we're going to do this. Now we're doing the surgery at 2:00 in the morning without any good planning, and the patient had neurologic deficits. And I don't know yet if those will resolve, but that's an example of we could have found and done this earlier, faster, cheaper, prevented the patient outcome that wouldn't have been there otherwise. And those stories are not uncommon. I mean, on a regular basis, we see patients who are struggling to get treatments done, but because they can't, they end up sicker in the emergency department, or they show up because they know that we can facilitate things in a way that can't happen on the outpatient world.
Well, this is why the work that you're doing is really, really important. I think, it's crucial. And, a lot of our listeners out there, they come from healthcare systems, from the pharmaceutical industry, and many of them work in the area of market access and reimbursement. So I think they'll really appreciate the work that you're doing there in North Carolina and your perspective. So thanks for your service. And again, Representative Reeder, really it was a pleasure to have you on the podcast. I think you shared a lot of important insights. So thanks again for being here.
Well, thank you very much. I always appreciate the opportunity to share the story of what we're trying to do to encourage patients to continue to struggle to get the care that they need. Because one of the things that I know in looking at the data is too many of our patients and physicians give up and settle for something that is less than what it could be, or they just believe that they can't get the care that they need. And I know it's frustrating and it's hard, but I think until we continue to push back and advocate for, we pay premiums every month, and we need to make sure that they're providing the services that we need. So thanks for the opportunity to share this story.
Yeah, no, thank you for coming on. I think this is going to be great. Thanks again.
Thank you. Well, thank you very much.
All right. Thank you, Representative Reeder.